vitamins, right? Okay, what is this? So what is this? A child with alopecia, a child with a neural tube defect such as, this is called encephalocele. Usually when you have a defect in the vertebral column and the meninges are protruding out, it is called meningocele. Whereas whenever there is protrusion of the brain tissue because of the defect in calvarium, it is called as encephalocele. So this is basically occipital encephalocele. And look at this. What is this? This is periungual pigmentation, or otherwise known as knuckle hyperpigmentation. Knuckle hyperpigmentation is more in favor of a B12 deficiency, whereas your encephalocele or your meningocele are more in favor of a folic acid deficiency. Whereas when you have a child with alopecia and neuroregression, it is often due to biotin deficiency, right? Biotin deficiency. So alopecia means, alopecia with the neuroregression is biotin deficiency. Spinal cord defect is probably is due to folate deficiency. Very rarely it can be due to zinc or vitamin A. And the knuckle hyperpigmentation is a manifestation of B12 deficiency. Very oftenly asked questions in your pediatrics examination. Second, so what are all the other things that you need to know? Follicular parakeratosis. You all know vitamin A is responsible for epithelialization of your skin as well as mucosa. Whenever you have vitamin A deficiency, keratin accumulation will occur around the follicles, and this is called follicular parakeratosis. Follicular parakeratosis is a manifestation of vitamin A deficiency. Whereas parafollicular hemorrhages, hemopericardium, and you have a painful rosary, scorbutic rosary, and periosteal hemorrhages leading on to pseudo paralysis are manifestations of scurvy. Scurvy is what is the role of vitamin C? The role of vitamin C is cross collagen formation, as a result of which the first step in bleeding is vasoconstriction. For vasoconstriction, you need to have a proper collagen. So whenever you have a collagen deficit, either in the form of Ehlers-Danlos syndrome or poor cross-linking hydroxyproline formation such as scurvy, it will lead to prolonged bleeding. So the manifestation of scurvy is not only parafollicular hemorrhages but also hemopericardium. Hemopericardium, cerebral hemorrhage, it can manifest with pseudo paralysis of infants because of periosteal hemorrhages. The child will not be moving their limbs. That is called a pseudo paralysis. So painless rosary, it is often due to vitamin D deficiency, whereas painful rosary is often due to scurvy. It is often due to scurvy. And what about hemolysis in preterm? Hemolysis in preterm is mainly occurs as a result of vitamin E deficiency, because vitamin E is an antioxidant, and it prevents your RBC membrane from breaking down from the oxidant free radical. So when there is deficiency of vitamin A, your preterm RBCs are prone for oxidant free radical, leading to hemolysis in preterm. So hemolysis in preterm is due to vitamin E deficiency. Then, right, then you have, what is this? Look at this. What is this? There is cupping. Look at this. There is cupping. So this is called cupping, fraying as well as widening. Cupping, fraying and widening are manifestations of vitamin D deficiency. Yes. What is the treatment for vitamin D deficiency? The old treatment for vitamin D deficiency is STARS regimen. That is 6 lakh international units of vitamin D intramuscular. Then it is replaced by 3 lakh international unit once. Then it is replaced by 1.5 lakh international units one. But as of now, the treatment of then it becomes bolus dose. That is 60,000 international unit weekly once. What is that? 60,000 international units weekly once for about 8 weeks. But these high dose regimens are often prone for hypercalcemia, as a result of which All these regimens has been replaced by daily oral regimen of giving vitamin D3. What is this daily oral regimen? The daily oral regimen is less than 2 years you give 2000 international units for 12 weeks, whereas more than 2 years you give 3000 international units, not 30,000, 3000 international units for 12 weeks. So after 12 weeks of oral vitamin D, you will monitor for something called zone of provisional calcification. You know the role of vitamin D is to produce mineralization of the bony ends. So when there is, you need to identify after treatment when there is a mineralization of bony ends. Look at this, look at this X-ray, look at this X-ray. So after even 4 weeks of, even after 4 weeks of vitamin D treatment, there is a zone of provisional calcification here. This is called zone of provisional calcification. So this zone of provisional calcification indicates that the child has been suffering from simple wide nutritional rickets, or otherwise known as rickets due to poor sunlight exposure. And we have seen numerous cases of rickets during the COVID period because children are not properly exposed to vitamin D during that period. So zone of provisional calcification is very, very important. So what is the investigation of choice for nutritional rickets? The investigation of choice for nutritional rickets is 25-OH-D3. I repeat, the investigation of choice for nutritional rickets is 25-OH-D3, 25-hydroxy-D3. That is the investigation of choice. And you have two terms. One is insufficiency, another is deficiency. Insufficiency means it is 12 to 20 nanogram per ml, whereas deficiency is less than 12 nanogram per ml. That is called deficiency. As we discussed already, the treatment is 2000 international or 3000 international units daily into 12 weeks. At the end of 4 weeks, you need to look for zone of provisional calcification. If it is not there, you are dealing with a case of vitamin D resistant rickets, right? What are all the clues for rickets other than nutritional rickets? Normally, you have rickets onset between 6 months to 2 years. When the onset of rickets is less than 6 months of age, unless otherwise proved, it is not nutritional rickets. Exclusively breastfed infants unlikely to have nutritional rickets. So less than 6 months, it is unlikely to be due to nutritional rickets. Then approach to nutritional rickets. So what is the approach to nutritional rickets? Very, very simple. Always the first step is to look for pH, because your proximal renal tubular acidosis and distal renal tubular acidosis are prone for nutritional rickets. What do you mean by proximal renal tubular acidosis? In proximal renal tubular acidosis, you will lose excess phosphorus in the urine, as a result of which you will get hypophosphatemic rickets. Whereas in distal renal tubular acidosis, in order to retain H+, your calcium will be excreted into the distal part of the convoluted tubule, as a result of which you will get calcopenic rickets. So proximal renal tubular acidosis is characterized by phosphopenic rickets, whereas distal renal tubular acidosis is characterized by calcopenic rickets. Second, the next point is look for phosphorus. So when pH is normal, then look for phosphorus. If whether the phosphorus is high or phosphorus is low. If phosphorus is high, then you need to look for parathyroid hormone. You need to look for parathyroid hormone. If parathyroid hormone is high or low. If parathyroid hormone is high, invariably you are dealing with a case of chronic renal failure, because phosphorus retention occurs in case of chronic renal failure, and chronic renal failure is characterized by dystrophy of bones because of the presence of excess parathyroid hormone in response to hypocalcemia. Whereas another condition is low parathyroid hormone, which is nothing but hypoparathyroidism. So when phosphorus is high, you need to think in terms of parathyroid hormone. When parathyroid hormone is high, it is chronic renal failure. You need to look for urea and creatinine. When parathyroid hormone is low, then it is hypoparathyroidism unless otherwise proved. But majority of them, pH, there will not be any questions. P4 high, there will not be any questions. But majority of them will be concentrating on this low phosphorus. So when there is low phosphorus, when there is low phosphorus, low PO2, Again, look for parathyroid hormone, whether parathyroid hormone is high or parathyroid hormone is normal. Look at this, where you have low phosphorus and high parathyroid hormone, means then there are only three possibilities. So low phosphorus and high parathyroid means there are only three possibilities. Those three possibilities can be investigated by doing two tests. One is 25 hydroxy D3, another is 125 dihydroxy D3. Remember, when 25 hydroxy D3 is low, invariably we have already dealt with, you are dealing with a case of nutritional rickets. Whereas when 25 OH-D3 is low, then it means what? 1-alpha hydroxylase has a problem. As a result of which, when 125 dihydroxy D3 is low, you are dealing with a case of vitamin D dependent rickets that occurs as a result of defect in 1-alpha hydroxylase. Whereas when 125 dihydroxy D3 is very high, 125 dihydroxy D3 is very high means you are dealing with a case of vitamin D resistant type 2 rickets. Remember, one more clue for VDDR type 2 is presence of alopecia. What? Presence of alopecia and enamel abnormalities. And enamel abnormalities both are in favor of vitamin D resistant rickets type 2. Presence of alopecia and enamel defect. So this is the simple approach to resistant rickets, right? So what are all the other questions that will be asked? The most common question that will be asked is 1. When 25 OH-D3 is low, you are, along with low phosphorus, you are dealing with nutritional rickets. When 25 OH-D3 is normal, then you need to think twice. What about 125 hydroxy D3? When it is low, VDDR type 1. When it is high, it is VDDR type 2. Another clue is this VDDR type 1 and type 2 has its onset less than 6 months of age. VDDR type 2 is associated with alopecia and enamel defect. And one more point, always your phosphorus, low phosphorus should be associated with high parathyroid hormone. When your phosphorus is associated with normal parathyroid hormone, look at this. When your phosphorus is associated with normal parathyroid hormone, then it is a case of hypophosphatemic rickets. This hypophosphatemic rickets often involves lower limbs rather than your upper limbs. Remember, often asked question in your entrance examination is VDDR type 2, which is characterized by high 125 dihydroxy D3 along with what is this? Occurrence less than 6 months of age, alopecia and enamel defect. And one more point is when parathyroid hormone is low or normal in the presence of low phosphorus, it is a case of X-linked hypophosphatemic rickets. In this, you need to give phosphorus supplementation or in the form of Joule solution, JOULIE, that is called as what? Joule solution, which contains phosphorus. So this is the approach to resistant rickets. Definitely you will be getting one question in rickets, right? So what is this? You are dealing with a case of a tuft of hair over the spine. Remember, a tuft of hair over the spine, a lipoma over the spine, or sinus over the spine, all indicates that there is a spina bifida occulta. Spina bifida occulta means there is no protrusion of meninges or nerves. There is only defect in the vertebral column. Whereas when there is protrusion of meninges into the defect, it is called meningocele. But when there is protrusion of spinal cord into the defect, it is called myelomeningocele. Remember, in case of meningocele and myelocele, there will be a neurological deficit. Whereas in spina bifida occulta, there will not be any neurological deficit. Any tuft of hair over the lower spine, lipoma, always you need to think in terms of a underlying neural tube defect. Folic acid that has to be given for every mother during the periconceptional period. Periconceptional period means 1 month before conception and 2 months after conception. That is 0.4 milligram that you need to give. But when there is previous history of neural tube defect, when the mother has got one more child affected by neural tube defect, then you need to give 10 times the dosage. That means 4 milligram per day 2 months before and 3 months after conception. This is the treatment regarding folic acid with respect to spinal cord defects. Right. What are all the other vitamins that are associated with the characteristic feature that can be asked in your entrance examination? You all know B12 deficiency is associated with the circumcorneal vascularization. It doesn't mean that B2 deficiency, riboflavin deficiency is associated with the angular cheilitis or glossitis. Now, often asked question with respect to entrance examination is circumcorneal vascularization. Ataxia, again, vitamin E is responsible for deficiency is responsible for producing ataxia. That's why children with the pancreatic insufficiency or fatty malabsorption, because of poor absorption of vitamin E, they often get ataxia. So one of the investigation of choice for any ataxia is vitamin E levels. Gum bleeding. Gum bleeding is a manifestation of, as we already discussed, gum bleeding, hemopericardium, pseudo-paralysis of infants. All are manifestations of vitamin C deficiency. Normally, previously, vitamin C deficiency or scurvy occurs in children occurs in sailors who are devoid of taking some oranges. But at present, these vitamin C deficiency scurvy are happening in children with special needs or children with autism, ADHD, because most of them are food faddists and they love only certain foods and they will be devoid of these vitamin C containing foods such as orange. What is called ping pong skull? Ping pong skull is nothing but where you know the tennis ball ping pong. Okay, not tennis ball, that is your table tennis ball is called ping pong. What will happen whenever you put some pressure over that ball, it goes inside, and when you relieve the pressure, it comes out. That is called ping pong sensation. So this ping pong sensation occurs in the calvarium in cases of vitamin D deficiency. Right. Neonatal bleeding. There are 3 types of neonatal bleeding: early onset, classic, and late onset. So early onset, classic, and late onset. Less than 1 day is early onset. 1 day to 7 day is 7 day is your classic, and more than 7 day is your late onset. Early onset vitamin D, vitamin K deficiency bleeding are characterized by what? Mother taking ATT or mother taking anticonvulsant drug. These drugs are associated with the inhibition of vitamin D metabolism. So day 1 bleeding due vitamin E metabolism. Day 1 bleeding is due to mother taking some anticonvulsant or anti-diabetic drugs that interacts with vitamin E. Second point, classic bleeding. Classic hemorrhagic disease of newborn onset between 1 day to 7 days, which is because of absence of giving vitamin K at birth. And finally, vitamin K deficiency that occurs after 7 days is called as late onset HTN. So this late onset HTN is due to neonatal cholestasis or pancreatic insufficiency. You need pancreatic enzyme and you need gallbladder bile secretion for the absorption of fat soluble vitamins. So when fat soluble vitamins A, D, E, K, particularly K, cannot be absorbed because of cystic fibrosis which affects your pancreas or your gallbladder, is a cause for late onset hemorrhagic disease of newborn. So there are 3 types of HTN, vitamin K dependent HTN. Okay, what is called PIVKA? You all know that the role of vitamin K is gamma carboxylation of 2,7,9,10. Sometimes when any child comes with severe bleeding, epistaxis, cerebral hemorrhage or hematemesis, what will happen? Immediately we will tend to give FFP or vitamin K, particularly FFP, because we need to control the bleeding. So we are worried about the saving the baby and not worried about the diagnosis. But when your chief comes and asks, how do you know that it is due to vitamin K deficiency bleeding? Means simple. Because when you give FFP, your prothrombin time and partial thromboplastin time will be normal. So what will happen? You need to do PIVKA. PIVKA is what? Protein induced in vitamin K absence. 2, 7, 9, 10 are dependent on vitamin K. So when vitamin K is not there, the gamma carboxylation of 2, 7, 9, 10 cannot happen. So this non-gamma carboxylated 2, 7, 9, 10 is called as puca, that is protein induced in vitamin K absent. This is particularly useful to diagnose vitamin K deficiency, particularly when a child had received FFP, so that it normalizes your prothrombin time and partial thromboplastin time. Right, lower limb rickets, as we discussed already, don't worry, this will be shared to you, so it doesn't mean that you just watch. I am going to share this returned PPTs to you, PDF, so don't worry, just listen, enjoy. Lower limb rickets are mainly due to what? X-linked hypophosphatemic rickets. What is the clue I told you? Whenever your low phosphorus is associated with the normal parathyroid hormone levels, unless otherwise proved, it is a case of hypophosphatemic rickets, and the treatment here is your giving phosphorus and not vitamin D in the form of Julie solution, and this hypophosphatemic rickets predominantly involve your lower limbs. Okay, right. Then comes other things. What is this? Infantile tremor syndrome. You all know that B12 deficiency is associated with megaloblastic anemia, hypersegmented neutrophils. I repeat, whenever someone is asking you about B12 deficiency, you often say megaloblastic anemia, hypersegmented neutrophils. But apart from that, B12 deficiency, because of the involvement in adults, you get subacute combined degeneration of the spinal cord, whereas in children, B12 deficiency, the neurological manifestation is nothing but neuroregression. What do you mean by neuroregression? My 8-month-old child previously used to sit, now not sitting. My 8-month-old child usually sees and turns her head whenever it is called. Now it is not turning. So this is called neuroregression. So in all cases of neuroregression, in case of pediatric age group, you need to rule out vitamin B12 deficiency. Remember, in your entrance examination, when neuroregression is there in the question, and when you have B12 in is one of your choice, unless otherwise proved, B12 is the answer, unless otherwise proved, because the most common cause of neuroregression in India is B12 deficiency. And one more manifestation of B12 deficiency is infantile tremor syndrome. Okay, right. Apart from that, what else you can have with respect to B12 deficiency? Simple. B12 deficiency is also characterized by pancytopenia, because your DNA methylation, your DNA maturation of RBC, not only RBC but also your platelet and your WBC depends on this DNA maturation. DNA maturation needs B12. So in B12 deficiency, you will get pancytopenia. All cases of pancytopenia should be investigated for B12 deficiency. And one more time, because of the hemolysis, you will get increased LDH. So any anemia with increased LDH, hypersegmented neutrophils, pancytopenia, you need to rule out B12 deficiency. And people say, and for your entrance examination, you must be saying that chilling test is the investigation of choice. No, it is not chilling test. The investigation of choice for B12 deficiency is your methylmalonic acid, because B12 is the one which converts your methylmalonic acid into succinyl-CoA. So when B12 is not there, methylmalonic acid in the urine is increased. So the investigation of choice for B12 deficiency is methylmalonic aciduria. Infantile hypotonia, aphonia. Remember, you all know that when someone is asking about thiamine deficiency, you must be speaking about congestive cardiac failure, which is called as wet beriberi, and peripheral neuritis, which occurs as a result of thiamine deficiency. It is called dry beriberi. So, but in pediatrics, one more manifestation of thiamine deficiency is infantile aphonia, and this B12 deficiency, thiamine deficiency or B1 deficiency is also characterized by RBC transketolase levels, because when the investigation of choice for thiamine deficiency is to look at this RBC transketolase level. When RBC transketolase levels are low, it indicates that there is an underlying thiamine deficiency. And what is this RBC glutathione reductase? Again, like RBC transketolase, your RBC transketolase, glutathione reductase, not transketolase, RBC glutathione reductase depends on riboflavin deficiency. So in riboflavin deficiency, your RBC glutathione reductase will be high. Remember, riboflavin deficiency, apart from angular cheilitis and glossitis, causes very good circumcorneal vascularization, a very, very important MCQ that is often asked in your NEET. Angular cheilitis, as we discussed, riboflavin deficiency, developmental delay along with alopecia. Just now we have discussed that we have discussed, whenever you have a case of neuroregression along with alopecia, unless otherwise proved, it is a case of biotin deficiency. Remember, very important for your entrance examination. Whenever you have a case of neuroregression along with the alopecia or dermatitis, unless otherwise proved, it is a case of biotin. Biotin deficiency is often a very frequently asked question as by your NEET as well as your innocent. Right, what is the role of avidin? You all know that avidin binds your biotin and it is present in raw egg. So when someone is eating raw egg, it will bind your biotin, and biotin availability become less. So by boiling your egg, your avidin will be lost, so that biotin will be available in your food. So remember, biotin, neuroregression, dermatitis, alopecia, avidin, boiled the egg. So these are all the 5 things that are very important with respect to biotin. Right, maize eating population. In term, you all know that your pellagra is characterized by deficiency of tryptophan or niacin, the precursor. Remember, in maize eating population, this tryptophan will be in the bound form and cannot be released to the blood, characterized by the manifestation of diarrhea, dermatitis and dementia. Diarrhea, dermatitis and dementia, as well as the 4th D is called death, which occurs as a result of niacin or tryptophan deficiency. And this has been discussed. Neuroregression is a manifestation of biotin. Pancytopenia, as already discussed, is a manifestation of B12 deficiency. Urine methylmalonic acid, just now discussed, B12 deficiency. Diarrhea, dermatitis, dementia is characterized by deficiency of tryptophan or niacin. Homocystinuria, remember, in pyridoxine deficiency, B6 is associated with 2 things. One is homocystinuria. In homocystinuria, we use pyridoxine B6, and one more condition, in people receiving INH. INH causes peripheral neuropathy by destroying your B6. So all children or adult who receives INH should receive your what? B6. Should receive your B6 or pyridoxine. One more ATT drug that is associated with the peripheral neuropathy is very good, cycloserine. So whenever the child is on isoniazid alone, they should be given a supplementation of pyridoxine 10 milligram, that is available as Benadryl. Whereas whenever the child receives cycloserine, the child should receive 50 milligram of pyridoxine, that is your Benadryl. Right, very important. All one-liners I am just discussing. Since we don't have much time to discuss many things, I am going very fast. So this will be useful. So instead of going very slow, I am going very fast, because this is basically a revision rather than a elaborate session. Right, refractory seizures in newborn, very important. You all know that GABA is a neuroinhibitory transmitter, whereas aspartate is neuroexcitatory. Whenever your neuroinhibitory transmitter such as GABA is low, the excitation will become more, as a result of which you will get seizures in the newborn. This refractory seizures in newborn can also be manifested as increased fetal movements when the child is inside the uterus. The GABA is dependent on pyridoxine. So one manifestation of pyridoxine deficiency is refractory seizures in newborn. The clue is increased intrauterine movements in the fetal life. Very important. The mother must be saying that the child is like a boxer and kicking the mother's uterus inside to a great extent, but it is not so. The more frequent kicking indicates that it is an intrauterine seizure and it is due to pyridoxine deficiency. More the kicking inside means more the chances for seizures when the child is born. That child should be treated with a dose of pyridoxine. Burning foot syndrome often not asked a question. It is due to pantothenic acid. Wimberger sign, you all know that ringed epiphysis in scurvy is called Wimberger sign. A zone of rarefaction in the metaphysis is called Trummerfeld zone. That is also again a manifestation of scurvy. And finally, what is this important question? Tetany not responding to calcium. Remember, tetany not responding to calcium. You all know that tetany, which occurs as a result of hypocalcemia, will be resolved by giving a dose of IV calcium gluconate. But even after giving IV calcium gluconate, if tetany doesn't resolve, it indicates that there is an underlying magnesium deficiency. There is an underlying magnesium deficiency. Very, very important, because magnesium is responsible for the action of calcium. So hypomagnesemia should be considered when tetany is not responding to IV calcium gluconate. Right. So what is this? Diarrhea, dermatitis, dementia, which often is due to maize eating population, the deficiency of, what is that? Tryptophan, niacin, etc. Right. Flaky and vitamins more or less over. Flaky paint dermatosis. Flaky paint dermatosis is more often a manifestation of kwashiorkor. Kwashiorkor is due to protein deficiency rather than calorie deficiency. The manifestation of protein deficiency or amino acids in skin is flaky paint dermatosis. Just like flakes of paint are falling from the wall, your skin will look like that flaky paint dermatosis. And the flaxine is the manifestation of protein deficiency in your hair. Alternative areas of pigmentation and depigmentation. Flaky paint dermatosis and flaxine are manifestation of protein deficiency, severe acute malnutrition, that is called kwashiorkor. Whereas loss of subcutaneous fat, which occurs as a result of energy deficit, which is characterized by marasmus. So loss of subcutaneous fat in the face is called as monkey faces, and loss of subcutaneous fat in the buttock is characterized by baggy pant appearance. So this baggy pant appearance and monkey faces occurs in marasmus. Energy deficiency leading to kwashiorkor. Energy deficiency leads to marasmus, whereas protein deficiency leads to kwashiorkor. Right. And you all know that. One more point. Severe acute malnutrition. What are all the points for severe acute malnutrition? The points for severe acute malnutrition is, what are all the points? Weight for height less than third centile, point number 1. Presence of bilateral pedal edema and presence of loss of subcutaneous fat. And finally, mid upper arm circumference of less than 11.5 centimeter. So even when one of these things are present, you will call it as severe acute malnutrition. The previous definition of kwashiorkor and marasmus has been clubbed together right now in the definition of severe acute malnutrition. The kwashiorkor points such as edema is included. The wasting of marasmus is included as loss of subcutaneous fat and mid upper arm circumference, and along with weight for height. Right. So mid upper arm circumference less than 11.5 centimeter is called severe acute malnutrition, whereas mid upper arm circumference between 11.5 to 12.5 centimeter is called as moderate acute malnutrition. More than 12.5 centimeter is called as normalcy. So how to calculate this? We have a special tape called Shakir's tape. In that Shakir's tape, if you get red colored things, it is called as severe acute malnutrition. Invariably, it means that your mid upper arm circumference is less than 11.5. If you get yellow, means it is 12.5 to 11.5. It is called moderate acute malnutrition. If it is more than 12.5, it is green in color. It is called, in Shakir tape, it is called no malnutrition. Along with that, one more deficiency that is often asked with respect to minerals are zinc deficiency, which are characterized by hypogonadism, poor wound healing, acrodermatitis enteropathica. That is, you have dermatitis perioral, perifacial, perioral, perianal, as well as your ends of your fingers and toes. This is called periorifacial dermatitis. This is called acrodermatitis enteropathica. They are also prone to severe infections because of the poor cell-mediated immunity due to the deficiency of zinc. And one more good point is neutropenia with IRIDA. What is called IRIDA? IRIDA means iron resistant iron deficiency anemia. We often think that whenever you see a case of microcytic hypochromic anemia, we often think that it is due to iron deficiency, but it is not so. It can also be due to LUST. L stands for lead, U stands for copper, S stands for sideroblastic anemia, and T stands for thalassemia. So thalassemia. So microcytic hypochromic anemia, other than iron deficiency anemia, it is characterized by LUST. LUST means for L for lead poisoning, U for copper deficiency, S for sideroblastic anemia, and T for thalassemia. So one of the cause for IRIDA, iron deficiency, IRIDA is Even when you give iron, the microcytic hypochromic anemia is not responding, means when it is associated with the low neutrophils, you need to consider consider the diagnosis of copper deficiency. Very, very important for your entrance examination. And finally, cardiomyopathy. Cardiomyopathy is due to what? Selenium deficiency. Selenium deficiency. So, and what are all the things you are seeing right now? So, what is this? This is called monkey faces. This is called baggy pant appearance. This is called as flax sign, and this is flaky paint dermatosis. These are all the manifestations of severe acute malnutrition. And this is your Shakir step. Red color means less than 11.5. Yellow color means 11.5 to 12.5. More than 12.5 means normal. So what is this? This is called stadiometer. What is this? This is called stadiometer. Stadiometer means you need to measure the height of the child. Whereas infantometer means you need to measure the length of the child. Length of the child means less than 2 years. Height of the child means more than 2 years. Height is measured by stadiometer and length is measured by infantometer. Okay, right. So this has been discussed. And one more point with respect to say tape, I told you about Shakir step. And another important revision points with respect to your severe acute malnutrition is when weight for height is reduced, it is called acute malnutrition. It is otherwise called as wasting. Less than -2 standard deviation. Less than -3 standard deviation means severe. Less than -2 means acute. Less than -3 means severe. Okay, right? So weight for height means wasting, that is acute malnutrition. Height for age means stunting, that is called chronic malnutrition. Weight for age means that is acute on chronic malnutrition. Acute on chronic malnutrition. Again, this last UNICET have asked this question, that is weight for age is affected, that means acute on chronic malnutrition. One question was asked in the recently concluded UNICET examination. Right, and another very, very important point with respect to ORS, oral rehydration solution. Oral rehydration solution, very, very important for your entrance examination. One second. Sorry. Okay, so during the olden period, the first ORS was standard ORS. The first ORS was standard ORS. It is mainly meant to treat cholera, where the osmolality of secreted stool is high. So that the osmolality is 311 milliosmol per kilogram. 311, one second, milliosmol per kilogram. Okay, ma, 311 milliosmol per kilogram, right? Whereas, one second, 311 milliosmol per kilogram, in which the glucose secretion is high and sodium secretion is high. Later on, they found that the majority of cholera is mainly due to viral diarrhea, particularly rotavirus, Norwalk virus, in which the amount of glucose and amount of sodium that is secreted into the intestine is less. So the osmolality of old ORS has been reduced from 311 to 245, an important MCQ, 311 to 245, because they had reduced the sugar value, glucose value from 111 to 75 and the sodium value from 90 to 75. So this is called Risomol or standard ORS right now. Reduced osmolality or new WHO ORS. So this is old, this is new. Repeat, new ORS osmolality is 245, where with equal volumes of sodium and glucose 75 each. Whereas old standard ORS is characterized by excess sodium and excess glucose. Glucose 160, sodium 95. Then they found that one more solution called rehydration solution for malnourished children, otherwise called as Risomol, in which because of hypotension, the renin angiotensin aldosterone system will be acting so much, as a result of which children with severe acute malnutrition will be having sodium retention. So in that, instead of giving normal sodium, they will reduce the sodium amount in the ORS solution. So what does it mean? Here in say Risomol, equal volumes of sodium and potassium, that is 45 sodium and 40 potassium. Remember, 45 sodium and 40 potassium they made, and remember they are at risk for hypoglycemia, as a result of which the sugar value has been increased to 125. The sugar value had been increased to 125, and here the osmolality is 300. I repeat again, my dear friends, the osmolality of double standard ORS is 311, new ORS is 245, whereas Risomol is 300. The sodium content was 95 with respect to old, reduced to 75 in new WHO ORS, which is reduced to 45 in Risomol. Third, the glucose value in the old ORS is 111, which is reduced to 75 and increased to 126 in Risomol. Potassium value in case of old and new ORS is 20 each, but it has been increased to 40 in case of Risomol. Very, very important chart. Okay, right. Okay, this has been discussed. One more revision, just have a look. Let's go for the next one. Right. So what about milk? Foremilk, hind milk. Okay, foremilk is rich in water, so it quenches the thirst, whereas hind milk is rich in nutrition. Hind milk is rich in nutrition, so it quenches the what? Satiety. So foremilk is meant for thirst and hind milk is meant for satiety. Right. What is called colostrum, transitional milk, and then mature milk? First 4 days of milk secretion after birth is called colostrum. It contains very, very, very rich immunoglobulins to protect the child against infection when it is out of the womb. So remember, the first vaccine that we are giving the child is not your BCG OPV. It is nothing but your colostrum because of the rich immunoglobulin levels. Right. Then what about what is the difference between cow milk and breast milk? Remember, your breast milk contains more carbohydrate, less proteins, whereas your cow milk contains more protein and less carbohydrate, right? Whereas your cow milk contains more of whey protein, which is less allergic. Your breast milk contains more of whey protein, which is less allergic, whereas cow milk contains more of casein, which is more allergic. Whereas the fat in both breast milk and cow's milk are one and the same, right? Next point. What is this? Breast milk can be stored in, very, very important question. So in room temperature, 6 hours, whereas when it is stored between 2 to 8 degrees Celsius 1 day, whereas when it is stored in freezer, it is for 3 months. Very, very important MCQ. Room temperature means 6 hours you can store it and you can use directly. You can give the breast milk directly to the child, provided it is stored properly in a utensil. Okay, what is this? This is called ambiguous genitalia. So what is this? Is it a penis? We don't know. But whether it is a under-virilized penis, we don't know. Whether it is a virilized clitoris, we don't know. So this is previously called as hermaphrodite. So no, you can't suppose to say someone is a hermaphrodite, because even when you pronounce it, it looks very, very ugly. Then the term ambiguous genitalia has replaced your hermaphrodite, but the final thing that we use right now is atypical genitalia. Whenever you have confusion, what is this actually? Whenever you have confusion with respect to identification of the sex of the genitalia, we will call it as atypical genitalia. And remember, the most common cause for atypical genitalia is congenital adrenal hyperplasia. Okay, due to deficiency of enzymes involved in adrenal biosynthetic pathway. A biosynthetic pathway. Okay, remember, whenever any child is having atypical genitalia, what is the approach? The answer is very, very simple. You need to remember aldosterone synthesis pathway which involves 21 alpha hydroxylase and 11 beta hydroxylase. In 21 alpha hydroxylase and 11 beta hydroxylase, what will happen? The cortisol is not formed. As a result of excess 17 hydroxyprogesterone will be diverted to the production of testosterone. As a result of which you will get precocious puberty in a boy and ambiguous genitalia in a girl. So 21 alpha hydroxylase and 7 and 11 beta hydroxylase are characterized by precocious puberty in boys and atypical genitalia in girls. And what will happen in 21 alpha hydroxylase, which is characterized by absence aldosterone, as a result of which you will get hypotension. Whereas 11 beta hydroxylase is characterized by excess 11 deoxycortisol, which has got some of the activity of your aldosterone, as a result of which your BP is high in case of 11 beta hydroxylase, whereas your 17 alpha hydroxylase and 1720 lyase are involved in the production of testosterone. So what will happen in 17 alpha hydroxylase and 1720 lyase, testosterone production will not be there, as a result of which you will get atypical genitalia in a boy and normal genitalia in a girl, because girl doesn't require any testosterone. Absence of testosterone indicates that the genitalia will become female. Okay, right. And finally, right, okay, so in these two instances, 17 alpha hydroxylase and 1720 lyase, what will happen? The excess 17 hydroxyprogesterone will be diverted to the production of aldosterone, as a result of which both of them are associated with hypertension. Both of them are associated with hypertension. Remember, except 21 alpha, your 11 beta hydroxylase, 17 alpha hydroxylase and 1720 lyase are associated with the hypertension because of the excess aldosterone secretion. And finally, what will happen in 3 beta HST deficiency? In 3 beta HST deficiency, what will happen? Your aldosterone is not formed, so hypotension will be there, and your androstenedione will be formed. Since the androstenedione will not be converted into testosterone, so excess androstenedione, what it will cause? Excess androstenedione in boys leads to what? It doesn't have the effect, it cannot work as effective as testosterone, as a result of which 3 beta HST is associated with hypospadiasis in boys. Hypospadiasis in boys. Whereas this excess minimal low potent androstenedione in girls, leading to what? Hirsutism, voice change and acne. Hirsutism, voice change and acne. And your 3 beta HST is associated with low BP. Okay, right. And finally, star protein deficiency. Star protein is the one which transports your cholesterol into the mitochondria. When star protein is not there, cholesterol cannot be shifted to mitochondria, as a result of which no aldosterone, cortisol, testosterone, nothing is produced, as a result of which it is lethal in utero. Right? This is all about your congenital adrenal hyperplasia. Remember, what is the investigation of choice for congenital adrenal hyperplasia? 17 hydroxyprogesterone. What is the investigation of choice? 17 hydroxyprogesterone levels is the investigation of choice, and 17 hydroxyprogesterone is the investigation of choice. And one more point, when you need to suspect any boy shock comes with shock in the second week of life, and it shows low sodium and high potassium along with the high metabolic acidosis, unless otherwise proved a case of Addison's crisis, which is often a manifestation of congenital adrenal hyperplasia in boys. Any boy shock newborn second week after birth with hyponatremia, hyperkalemia, metabolic acidosis should be considered as a case of congenital adrenal hyperplasia. The next investigation of choice is 17 hydroxyprogesterone levels. Right. Then 17 hydroxyprogesterone levels. Okay. Then comes your, what is the, previously you have a child with the congenital adrenal hyperplasia, but right now the mother is pregnant. What will you do? So invariably you need to start the mother on dexamethasone. Invariably you need to start the mother on dexamethasone, because by starting dexamethasone, your fetus, the dexamethasone given to the mother will reach the child through the placental circulation, and the fetal pituitary will see the maternal dexamethasone or cortisol, and so that the excess 17 hydroxyprogesterone will not be converted into testosterone, as a result of which there will not be any virilization of a female genitalia. Right, female genitalia. So you give dexamethasone as early as the pregnancy is confirmed. Then at 10 weeks, you do a chorionic villus sampling 10 to 12 weeks, and then find out whether it is a boy or girl. You can do a karyotyping. Boy means you can stop dexamethasone. Nothing is going to happen because you are nothing. The boy will be happy by seeing his enlarged penis because they are more prone for precocious puberty. Whereas in girls, if it is a girl, if the karyotype is a girl, then you need to give, karyotype is a girl, then you need to give, what is that? A girl, you need to give dexamethasone till the child is delivered, and then put the child on lifelong fludrocortisone or hydrocortisone. Hydrocortisone in all cases of congenital adrenal hyperplasia, but fludrocortisone only in cases with hypotension. In cases of 17 alpha hydroxylase, 11 beta hydroxylase, and 1720 lyase, already there is hypertension and there is no need for giving fludrocortisone. Only hydrocortisone is enough to shut the fetal pituitary, diverting your 17 hydroxyprogesterone to the testosterone. Right. Okay, what are all the possible questions that can be asked in the newborn? Let's see. So what is this actually? What is this actually? Look at this. Look at this. There are some loosened things. There are some loosened things in the right hemithorax. Loosened thing, and I can trace the border of diaphragm on the left, but I can't trace the border of the diaphragm on the right. So whenever you have a child with a neonatal respiratory distress, please rule out some surgical condition. The two most common surgical conditions that will be given to you are, one is tracheoesophageal fistula, another is congenital diaphragmatic hernia. In congenital diaphragmatic hernia, because of the defect in the diaphragm, the intestinal loops will move from the abdomen to the chest, as a result of which the abdomen will be empty and become scaphoid. So whenever any neonatal distress along with the scaphoid abdomen, unless otherwise proved, it is a case of congenital diaphragmatic hernia. Point number 1, congenital diaphragmatic hernia. In congenital diaphragmatic hernia, it is a contraindication for CPAP. Why it is a contraindication for CPAP or bag and mask ventilation? Because when you give bag and mask ventilation or CPAP, it will go to the air will also go into the, apart from going into the lungs, it will go into the intestine. This intestine, which is occupying the place of the lung in the thorax, will extend further, leading to poor compromisation or leading to poor expansion of lung, as a result of which bag and mask ventilation is contraindicated in children with congenital diaphragmatic hernia. Okay, second point, whenever any child has got neonatal respiratory distress along with the frothing from the mouth, means it is tracheoesophageal fistula. The next best thing is you need to put the NG tube, and when you see a coiling of NG tube here, it is a case of tracheoesophageal fistula. Second. Third point is another neosurgical condition that is often asked in your entrance examination is any child with neonatal respiratory distress along with reduced air entry in the left upper chest wall, means it is a case of congenital lobar emphysema. It is called congenital lobar emphysema, or this is 4 times it was asked in your INICET. Okay, what is that? Congenital lobar emphysema. That is due to the defect in bronchial wall cartilage, as a result of which air goes inside but cannot come out due to ball valve mechanism. So you will get a loosened lung on the left upper lobe with reduced air entry, as a result of which it is a functionless lung. So your respiratory distress will be there, but the child will not be as toxic when compared to your congenital diaphragmatic hernia or your tracheoesophageal fistula. Remember, neonatal respiratory distress with the reduced air entry over the left infraclavicular area is congenital lobar emphysema. Neonatal respiratory distress with the frothing from the mouth is tracheoesophageal fistula. Neonatal respiratory distress along with the scaphoid abdomen is a case of congenital diaphragmatic hernia. Right. So with respect to, what is this? With respect to neonatal resuscitation, what are all the questions that will be asked? The first question is, whenever you want to do neonatal resuscitation, the 3 things that you need to ask is whether it is a term or preterm. whether the child is crying or not, whether the tone is proper or not. Apart from that, why it turn, apart from that, you need to decide whether you are going to do delayed clamping or not. In case of term baby crying after birth, delayed cord clamping is allowed. Whereas in case of birth asphyxia, you need to resuscitate the baby. Do not worry about the delayed cord clamping. So delayed cord clamping, that is clamping the cord 30 seconds to 1 minute after birth, is contraindicated in children with birth asphyxia, because in birth asphyxia you need to immediately start resuscitation of the baby. Right. So what is this? What is this position called? This is called sniffing position. Putting a roll of towel under the shoulder blade so that your nasopharynx, your trachea, and your nose will be in the straight line, so that the air can grow, can go and come out very easily. This is called sniffing position. One. Second point is, you all know that whenever first point is sniffing position. Second point, what else? As far as cardiopulmonary resuscitation is concerned, what you will do? You can do either two thumb technique or two finger technique. Remember, two finger technique is not at all followed now. It is two thumb technique because it produces adequate pressure over the cardiac to have a cardiac massage. Second point. Third point, what is this called as? This is called laryngeal mask airway. So what does it mean? Whenever, what is the first step in resuscitation? Step one is, whenever the child heart rate is less than 100 to more than less than 100 or more than 60 to 100 per minute means you need to start bag and mask ventilation. 60 to 100 per minute means start bag and mask ventilation when the heart rate is. At the end of 15 seconds of bag and mask ventilation, you need to assess whether the heart rate is increasing or not. If the heart rate is not increasing, then it means that there is a problem in Mr. SOPA. There is a problem in Mr. SOPA. What is Mr. SOPA? M stands for whether you are snugly fitting the mask covering the mouth and the nose, whether it is correctly placed or not, or for reposition of the neck, whether the trachea, nasopharynx and nose are in the straight line or not. S stands for suctioning. You need to suction the mouth properly so that all secretions can be taken out, so that whenever you press your ambu bag, the air goes inside the mouth apart from your nose. And O stands for open the mouth. By closing the mouth, and if you do bag and mask, it won't the air won't go entirely through nose, so that the mouth should be open. And P stands for adequate pressure. You need to put adequate pressure over the ambu so that the air goes inside. And finally, when all of these are not, even after correcting your mask, your reposition of the neck, you suction and open the mouth. Despite doing all this, still the child's heart rate is not increasing, means then go for alt. A stands for alternate. A stands for alternate means two things. One, if you have the ability to do endotracheal intubation, then intubate the child. If you don't have the ability or previous exposure to endotracheal intubation, then comes your what is this laryngeal mask airway. You need to just take the laryngeal mask airway and just go blindly into the mouth, and this area will go and snugly fit into the laryngeal inlet, and the bag can be connected to this area, and you can do a bag and tube ventilation. So if you are well versed enough, bag and endotracheal tube intubation. If you are not well versed enough, you can do laryngeal mask airway. Okay, right. If the heart rate is less than 60 per minute, apart from ventilation, either with the help of a bag and mask or with the help of a endotracheal intubation or laryngeal mask airway, you need to carry out cardiac massage. What is the ratio of cardiac massage with respect to bag and mask ventilation or bag and tube ventilation? It is 3:1 ratio. What is this 3:1 ratio? 3 chest compression, that is with respect to two thumb technique, and 1 ventilation. So you need to do totally, you need to do 120 events per minute. In that, 90 is meant for chest compression and 30 is meant for bag and tube ventilation. Right, bag and tube ventilation. This is 90, 30, 120 events per minute. Right. Despite giving 120, despite doing successful cardiopulmonary resuscitation, at the end of 1 minute, if the child is not showing any improvement in the heart rate, means then you need to start adrenaline. The normal adrenaline is 1 in 1000. You need to mix with the 9 ml of normal saline to convert 1 in 10,000 adrenaline, and you start giving 0.1 ml to 0.2 ml per kg of, the new thing is 0.2 ml per kg of adrenaline through the umbilical vein. Umbilical vein is the best easily available vein even in conditions of shock. So you will give 0.2 ml per kg of adrenaline through the umbilical vein, followed by a fixed 3 ml normal saline bolus. It is fixed right now, normal saline bolus, right? If you can't get umbilical vein but you have intubated the child, means then you can give a single dose of endotracheal adrenaline, but here instead of 0.2 ml per kg you will give 0.5 ml per kg over the endotracheal tube. And finally, okay, everything is over. What is this? What is this actually? This is called CPAP, continuous positive airway pressure. This is called as what? CPAP, continuous positive airway pressure. What is the role of it? See, remember, when your heart rate is less than 100 per minute, you start bag and mask ventilation. When your heart rate is less than 60 per minute, along with the bag and mask or bag and tube ventilation, you start your cardiac massage. But when you have a persistent cyanosis or labored breathing, but your heart rate is more than 100 per minute, means there is no need for bag and mask ventilation, there is no need for cardiac massage, but this persistent cyanosis and labored breathing should be supported by a good alveolar ventilation. This alveolar ventilation can be given by means of a CPAP, continuous positive airway pressure. Very, very, very important. So persistent cyanosis or labored breathing but heart rate is more than 100 per minute, means you need to connect the child through nose, through nasal prongs to CPAP. What is CPAP? CPAP contains, it is nothing but CPAP. What is called CPAP? Let me complete it. What is CPAP? CPAP is nothing but, so remember, you have one is oxygen and another is air, so that they will be mixed in a chamber called, this is called blender. This is called as, not blender, this is called blender. So one is oxygen tube, another is air, so that they will be mixed by blender, and it will reach the baby through one limb, inspiratory limb, goes inside the, okay, inspiratory limb, and then wait. So air and oxygen blender comes out and they will be dip. Okay, it goes inside the nose. It goes inside the nose, and the expiratory limb is connected to a, column of water, so that what will happen, the air that comes out during the expiration, that goes inside, so just go inside the column of water. As a result of it, some PEEP is produced. What is called PEEP? Positive end expiratory pressure. What is that called as? Positive end expiratory pressure. By producing positive end expiratory pressure, your alveoli gets distended, so that more and more alveoli will be recruited for oxygenation, and this is how your CPAP works. So CPAP works by increasing positive end expiratory pressure, because the expiratory limb is dipped into the column of water to produce that kind of pressure, right? CPAP, PEEP, CPAP, PEEP, that's it. CPAP indication is what? Heart rate is more than 100 but labored breathing and persistent cyanosis. Dot. Okay, what is called delayed cord clamping? 30 seconds to 60 seconds after birth. Sniffing position is roll of towel under your shoulder blade. Indications for a PPV, I told you. Indication of CPAP, indication of cardiac massage, everything was discussed just now. I don't want to repeat it and waste your time. Two thumb technique over, CPR is over. Contraindication of PPV is congenital diaphragmatic hernia. Best route for drug administration is umbilical vein. If umbilical vein is not possible, peripheral vein. If peripheral vein is not possible, you can do intraosseous route. Very, very important question. Intraosseous route, that is, you take a bone marrow needle. When line is not, you can't get a line, then you take a bone marrow needle and put 1 inch medial and 1 inch below your medial epicondyle of the tibia, so that you can directly give fluids to the medulla. Okay, so one of the method for giving intravenous fluid except oxygen, anything can be given through intraosseous route. The last resort, whenever you don't get any vein, is intraosseous route. This question was asked frequently in set. Okay, when failed cardiac massage, what is the drug of choice? Adrenaline. When what to do in case of failed intubation? Laryngeal mask airway or endotracheal intubation. Remember, there is no role of oral because whenever in case of birth asphyxia, already there is lactic acidosis accumulation. So by giving oral, you are adding lactic acid further to the body, which can lead to anaerobic metabolism. So there is no role of oral right now. Second, previously people used to do tracheal meconium's aspiration from the trachea in meconium aspiration syndrome. But remember, in case of meconium aspiration, the meconium present in the trachea has to be taken out. But what will happen? For that, you need to take a laryngoscope and see the laryngeal inlet either through the endotracheal tube or directly you need to look into the tracheal meconium and you need to take all the meconium out. By this time, if you spend all these time for laryngoscopy, endotracheal intubation, suctioning of the meconium, by the time you start suctioning of the meconium, the child would have already gone for birth asphyxia or hypoxic ischemic encephalopathy. That's why the recent guideline says that even in meconium aspiration syndrome, there is no need for tracheal aspiration. You can directly do bag and mask ventilation. I repeat, even in tracheal meconium aspiration syndrome, you can do bag and mask ventilation because it is easier to do rather than going for an intubation and suctioning your meconium from the trachea. And finally, is there any role of antepartum suctioning? What is called antepartum suctioning? The child, what is called antepartum suctioning? You know that the child was having fetal distress in utero and the child had passed meconium. So you have a meconium stained amniotic liquor. So some may say that yeah, as soon as the baby head is delivered, but before the delivery of the shoulder, you can start doing suctioning of the mouth. That is called antepartum suctioning. Again, antepartum suctioning has got no role in case of meconium, no role in case of meconium aspiration syndrome. No role of oral, no role of tracheal meconium aspiration. You can do bag and mask ventilation. No role for antepartum suctioning. Again, there is no role for delayed cord clamping. Again, there is no role for delayed cord clamping in case of birth asphyxia. You need to start resuscitation rather than allotting blood to the body. Apart from that, what are all the questions that can be asked? Apart from that, what are all the questions that can be asked with respect to newborn? Pink diaphers are often due to urate crystal. That is not due to hematemesis. It is due to urate crystals. Eosinophil laden sterile skin lesions are called erythema toxicum. Erythematous lesions of newborn is called erythema toxicum, which has got eosinophils under the base. It is a non-infective condition. Whereas keratin filled cyst in case of hot palate is called as keratin pearls, and the white papillar lesions in the face and nose is nothing but milia. All of them are benign conditions. Benign conditions. So benign condition. What do you mean by okay? But one thing that has to be worried is sclerema. Sclerema is not a benign condition. What is called sclerema? Sclerema is nothing but woody induration of the skin because as a result of oxidation of the subcutaneous fat which occurs in gram-negative sepsis such as pseudomonas. So sclerema is nothing but woody induration of the subcutaneous tissue mainly involving your chest and leads to poor expansion of the lung and leading to death of the baby. This sclerema is not a physiological entity and it occurs as a result of pseudomonas sepsis. Right, what are all the other definitions that you need to have? A child less than 2500 grams is said to be low birth weight. A child less than 1500 grams is said to be very low birth weight, whereas the child less than 1000 grams is said to be extremely low birth weight. This is mainly based on the weight of the child. Whereas the statistical definition is small for gestational age, appropriate for gestational age, and large for gestational age. Small for gestational age means less than 10th centile. Appropriate for gestational age means 10 to 90 centile, and the large for gestational age means more than 90th centile. Right. And apart from that, what are all the other things that you need to know? The normal newborn temperature is 36.5 to 37.5 degrees Celsius. Hyperthermia means more than 37.5 degrees Celsius. Remember, the only manifestation of hyperthermia is herpes as well as malaria. Remember, bacterial infection do not produce hyperthermia in newborn, rather they produce hypothermia. And then what is called hypothermia? A temperature of less than 36.5 degrees Celsius is called hypothermia. The temperature between 36 degrees Celsius to 36.5 degrees Celsius is called mild hypothermia or cold injury or cold stress. Temperature between 32 to 36 degrees Celsius is called moderate, and less than 32 degrees Celsius is called severe. Remember, the most often asked question with respect to entrance examination is your mild hypothermia, that is 36 to 36.5 degree Celsius. How to identify that? Whenever you keep one hand over the abdomen and another hand over the foot, the hand over the abdomen will be warm and the hand over the foot will be cold. This is the way you need to measure your cold injury or cold stress. This is often asked question in your entrance examination. And remember how to increase the temperature of the baby. The answer is very simple. When the child is more than 1800 grams, what you need is to do a kangaroo mother care, right? Kangaroo mother care. So these are all the things that we have explained right now. Okay, and what about the feeding in preterm? 1 second. What about feeding in preterm? Remember, children, a newborn less than 28 weeks will not have a good intestinal maturity. As a result of which, for newborn less than 28 weeks, you give intravenous fluids. That is otherwise called as total parenteral nutrition. Whereas for a newborn between 28 weeks to 32 weeks, the sucking swallowing coordination will not be there, but the intestine has got matured. So what will you do? You need to bypass your sucking, you need to bypass your swallowing, and so that you can put a nasogastric tube and orogastric tube and keep a tube in the stomach, and you can give even breast milk also. So for 28 to 32 weeks, you need to give nasogastric or orogastric feeding. And finally, the third one is Gokarnam or Palade feed. So between 32 to 34 weeks, swallowing will be there, but sucking swallowing coordination will not be there. So you bypass sucking by giving direct Palade feed so that the child can take Palade feeds between 32 to 34 weeks. And finally, by about 34 weeks, sucking swallowing coordination will occur so that you can give direct breast milk. Direct breast milk. Right. So finally, what are all the two scores of respiratory distress syndrome? Again, I am with respect to neonatology. The two scores for neonatal respiratory distress. One is Downey score. What is called Downey score? It contains 5 parameters: respiratory rate, retractions, air entry, added sounds such as grunting, and finally saturation. These are all the 5 parameters of Downey score, and you can have 0, 1, 2 for each and everything. So there are 5 parameters. So 5 into 0 is 0 and 5 to 2 is 10. So the minimum score is 0, maximum score is 10 in Downey score. 0 to 3 is mild respiratory distress. 4 to 6 is called moderate respiratory distress. 7 to 10 is called severe respiratory distress. Another classification for respiratory distress with respect to preterm alone is your Silverman-Anderson score. In Silverman-Anderson score, what are all the parameters? Very simple. One is nasal flaring. Second one is grunting. Third one is upper chest retraction. Fourth one is middle xiphoid retraction. Fifth one is lower chest retraction. Anderson score is mainly meant for preterm. Remember, the most common cause for respiratory distress in preterm is nothing but your hyaline membrane disease due to inability of the surfactant to produce. So what is the treatment for hyaline membrane disease? Very, very important. Remember, when the respiratory distress is less than 4, when the respiratory distress is less than 4, there is no apnea, there is no ground glassing, means the treatment of choice is CPAP, continuous positive airway pressure. It is not surfactant. For mild respiratory distress with a Downey score of 0 to 3 without apnea, without ground glass lung fills, is just CPAP. But when the score is between 4 to 6, but without apnea and without apnea and without ground glass or small whiteout lung, is you need to give insure. What is called insure? Intubation, surfactant administration, and extubation. So you need to intubate, you give surfactant, you extubate and connect it to CPAP. This is for Moderate respiratory distress, moderate means 4 to 6. Whereas severe respiratory distress means more than 7. Downy score more than 7, either with or without apnea, either with or without small whiteout lung means here the child definitely needs mechanical ventilation, so that you need to mechanically ventilate the child and you need to give your surfactant, right? And yes, this was discussed. What is called severe perinatal asphyxia? Remember, you have Apgar score. An Apgar score of 0 to 3. An Apgar score of one second. An Apgar score of 0 to 3 is severe, and an Apgar score of 4 to 6 for persistently for 5 minutes is called as severe perinatal asphyxia. Severe perinatal asphyxia means birth your Apgar score 0 to 3 after 5 minutes is severe. Your Apgar score 4 to 6 after 5 minutes is called mild or moderate birth asphyxia. Neonatal hypoglycemia, a serum calcium of less than total serum calcium of less than 8 milligram per deciliter in term, and less than 4 milligram, less than 7 milligram in preterm is called as hypocalcemia in newborn. Hypocalcemia manifestations are jitteriness, tetany, stridor, CCF, etc. Remember, neonatal hypoglycemia and hypocalcemia are more common in infant of diabetic mother. In the first 6 hours, they are more prone for hypoglycemia, seizures, whereas after 6 hours, they are more prone for neonatal hypocalcemia. Remember, one more cause for neonatal hypocalcemia is it can be either early onset or late onset. Early onset means less than 72 hours hypocalcemia. Late onset means more than 72 hours hypocalcemia. Remember, more than 72 hours means it can be due to cow milk ingestion. Remember, late onset hypocalcemia more than 72 hours is due to cow milk ingestion. Why it is due to? Because the calcium phosphorus ratio in cow milk is low. That means the phosphorus is high and calcium is low. So this high phosphorus chelates the calcium. As a result of which you will get hyperphosphatemic hypocalcemic rickets in late onset hypocalcemia, right? What about neonatal hypoglycemia? Yeah, blood glucose of less than 45 milligram per deciliter is called as neonatal hypoglycemia. Remember, if the sugar is between 20 to 45 milligram per deciliter and the child is not having any manifestations of hypoglycemia such as jitteriness, seizures or drowsiness, then you can continue breast milk. But when the blood sugar value is less than 20 milligram per deciliter, or even when between 20 to 45, but the child is having convulsion, seizure, lethargy, drowsiness, this is called symptomatic hypoglycemia. Symptomatic hypoglycemia means 20 to 45 milligram per deciliter, less than that, or even if it is asymptomatic, a blood glucose of less than 20 milligram per deciliter requires a 2 ml per kg of 10% dextrose. Okay, this is how you need to treat hypoglycemia. Remember, if the usual starting dosage is 6 milligram per kilogram per minute of sugar, you can go up to 12 milligram per kilogram per minute. But if the child requires more than 12 milligram per kilogram per minute, it is called as resistant hypoglycemia, and you cannot give glucose through peripheral vein, you need to give central vein. Second point, if your hypoglycemia requires more than, if your hyperglycemia persists more than 7 days or 1 week, again it is a case of resistant hypoglycemia. There are many causes such as glycogen storage disorders or fatty acid oxidation disorder, or in one particular specific condition in which the insulin levels are very high by the pancreatic tumor, that is called as, don't say insulinoma. In pediatrics, it is called nisidioblastosis. Very, very important question. It is called as what? Nisidioblastosis. Resistant hypoglycemia in pediatrics in newborn is due to high insulin secreting condition of pancreas. It is not insulinoma. It is called as nisidioblastosis. Very, very important MCQ with respect to your entrance examination. Okay, then what are all the things that we have discussed? So you have something called keratin. What is this? Epstein's pearls. And what is this? Erythema toxicum. And this hardened woodening of skin is called as peroxidate, due to oxidation of your subcutaneous fat that occurs as a result of scleroderma. Okay, it indicates pseudomonas sepsis. It indicates grave prognosis. Grave prognosis. Thank you. Right. Then with respect to milestones, very, very important. So today I am mainly going to concentrate on general pediatrics, not on systemic pediatrics. So we will have 20 more minutes. So what is this? What is this actually? A newborn just lifting the chin, usually occurs by about 2 weeks. Just lifting the skin usually occurs by about 2 weeks. Whereas in this, the newborn lifting the head 45 degree above the level of the ground, and this occurs by about 8 weeks. This occurs by about 8 weeks. 8 weeks. And what is this? The newborn just elevating the chest, as well as just elevating the chest as well as the upper chest as well as the head, and with the flexed elbow, and this occurs by about 3 months. Whereas the newborn elevating the head, the newborn elevating the chest with the extended elbow, it occurs by about 6 months. It occurs by about 6 months. Okay. Now, what is called crawling and creeping? Remember, very, very important. So often you get confused with respect to crawling and creeping. Remember, crawling and creeping. What is called crawling? Crawling means abdomen is touching the ground. Abdomen touching the ground is called crawling. It is usually occurs by about 8 months, whereas abdomen off the ground is called as creeping, which occurs usually by 10 months. Whereas bear walk usually occurs by about 12 months. So crawling abdomen touch the ground 8 months, creeping abdomen off the ground 10 months, and bear walk usually occurs by about 12 months. 12 months. Then what are all other important photos that can be asked for your set or your NEET? So what is this? The child is sitting. So what is this? Can anyone answer? I am happy many are watching. So what is this? So the child is sitting with arms support. So what is this? This is called tripod. So sitting with their own support from both hands is called tripod. Usually it occurs by about 6 months. Whereas what is the sitting without support? Sitting without support occurs by about 8 months. About by 8 months. So what is that? Sitting as well as turning diagonally towards source of sound. This is called pivot. This is called pivot. Usually occurs by about 9 to 10 months. Okay, tripod, sitting without support, and pivot usually occurs by about 9 to 10 months. Very, very important MCQ. Right. Again, many of us may do some mistake with this. So what is this actually? The child is able to stand, but with the support, and bears the entire weight. Look at this. The child can bear entire weight when made to stand. Many says that it is 1 year. It is not so. When supported, the child can bear the entire body weight in standing position by about MCQ 6 months. By about 6 months. Very, very important MCQ. And what is this? The child is cruising around the chair. Cruising around the chair usually occurs but 9 to 11 months. Cruising around the chair usually occurs by about 9 to 11 months. Right? Then comes, what is this? Standing with support, without anything. Standing with support, I'm sorry, standing without support usually occurs by about 12 months. And walking, okay, with support usually occurs by 13 months. 13 months. Walking with support usually by 13 months, and without support by 14 months. Support by about 14 months. Right. So what is this? What is this? The child can walk backwards, the child can jump, and the child can climb up with both feet in one step. What is called both feet in one step? Remember, this is the step. So left foot and then right foot in one step. again left foot in the next step, again right foot in the same step. So this is called climbing up with both foot in one step. This usually occurs by about 2 years. Remember, at 2 years, walking backwards, jumping and climbing. Can anyone tell me the difference between jumping and hopping? Can anyone tell me the difference between jumping and hopping? Remember, jumping means you are just jumping. Your both of your legs are above the level of the ground at the same time and going from one place to another. This is called jumping. Whereas hopping means one leg over the ground and another leg over the air, on the ground and another leg in the air. So this is called as hopping. Jumping occurs by about 2 years, whereas hopping occurs by about 3 years, and skipping occurs by about 5 years, and tricycle by about 3 years. About 3 years. So look at this. So what is this? Tricycle means 3 for 3. That's how you remember. Tricycle means 3 years. And then alternative step upwards. That is, you cannot keep both feet in one step. So you will keep one foot over one step, and you will use another step for your next leg. So alternative foots rather than simultaneous steps on one step. So this is called as, what is this? This is called as what? Alternate steps up usually occurs by about 4 years, 3 years. I am sorry. Alternative foot up by about 3 years, and alternative foots down by about 4 years. Down by about 4 years. Right. And then what are all these things? What are all these things? So look at this. The child is holding things in both hands. So this is called bidextrous grasp. This is called as bidextrous grasp, 4 months. And look at this. The child is having the toy in one hand. This is called unidextrous grasp, which occurs by 6 months. And then the child can transfer the objects from one hand to another hand. That is transfer of objects from one hand to another hand, again by about 6 months. Transfer of objects between one hand to another hand by about 6 months. And then radial grasp. What is called radial grasp? This is pen. I am holding like this. Radial grasp. So radial grasp by about 8 months. I am sorry, this is ulnar grasp. I am extremely sorry. So ulnar grasp by about 8 months. And then radial grasp by about 9 months. And finally pincer grasp between 9 months to 12 months. Between 9 months to 12 months. Pincer grasp between 9 months to 12 months. Grasp between 9 months to 12 months. Okay, very, very important. And what is this? What is this? Can anyone tell me what is this? Okay, so the child is removing the socks. So removing socks, removing shoes, removing hula, everything occurs by about 1 year. And the child is trying to put shoes by about 3 years. And the child can put shoelaces. Very, very important. Putting shoes by about 3 years, putting laces by about 5 years. Putting laces by about 5 years. And finally, what about the building blocks? Blocks. The child is able to build a block. So 2 block, 15 months. Okay. 3 block, 18 months. 6 block, the child can build 2 years. And then 9 blocks by about 3 years. By about 3 years. Okay. 3 years. And then a bridge by about 4 years. By about 4 years. Gate by about 5 years. And then step by about 6 years. So these are all the some of the milestones with respect to building blocks. With respect to building blocks. Okay, right. So what about IMNCI? Let's see. What about IMNCI? Let's see. So this was actually explained, mid upper arm circumference explained in detail, less than 11.5 SAM, 11.5 to 12.5 MAP, and more than 12.5 it is normal. It is normal. Okay, right. What is this? Pallor. So what are all the MCQs that can be asked with respect to pallor? You need to compare your hand with the child's hand. This is my hand. So this is child hand. So remember, when you have pallor in these areas, so that is called some palmar pallor. Some palmar pallor. Some palmar pallor means the hemoglobin is 7 grams to 10.9 grams per deciliter. What is called severe palmar pallor? What is called severe palmar pallor? Severe palmar pallor means grease also involved. That means hemoglobin is less than 7 grams per deciliter. What is the treatment of choice for some pallor and severe pallor? Remember, with respect to IMNCI, no pallor also requires treatment for a growing child. Between 6 months to 5 years, 1 ml of iron syrup twice weekly. That 1 ml contains what? 20 milligram of elemental iron and 200 microgram of folic acid. 20 milligram of elemental iron and 200 milligram of folic acid. This is prophylaxis. This is prophylaxis. Whereas what is the treatment for some palmar pallor? The same 1 ml daily into 2 months. It is called treatment, therapeutic. Whereas what is the treatment for severe pallor? You are not supposed to treat severe pallor at PHC. You need to refer the child. Right. Okay, pallor over. Then comes what is this? With respect to what? With respect to pneumonia. Very, very simple. So remember, pneumonia, with respect to pneumonia, a respiratory rate, the respiratory rate more than 60 per minute, more than 50 per minute, more than 40 per minute. More than 60 per minute, less than 2 months of age, more than 50 per minute, 2 months to 1 year, and more than 40, more than 1 year. Okay. So 3 parameters. One is fast breathing, second is chest indrawing. Third one is danger signs. What are all the danger signs? The general danger signs you all know. Not able to take feeds, vomiting, everything, lethargy, convulsions are danger signs for each and every parameters in IMNCI. But as far as respiratory system is concerned, a saturation of less than 90% is danger, and stridor at rest is danger. So what is this? For fast breathing pneumonia and chest indrawing pneumonia, the IMNCI says that you can give amoxicillin 80 mg per kg per day in two divided doses. For 5 days. That is the treatment of choice for both. Whereas severe pneumonia means you need to give ampicillin and gentamicin, and it comes under pink color, and you need to refer the child. This is called severe dehydration, right? And with respect to diarrhea, what are all the things that you need to know from starting to bottom? So one is sensorium. Second one is eyes sunken or not. Third one is skin pinch. Okay. Fourth one is thirst. These are all the parameters you will see. What is called some dehydration? Some dehydration means the child is irritable. Eyes sunken. Skin pinch goes back but less than 2 seconds. Thirst, vigorous thirst. This is some dehydration. What is the treatment of choice for some dehydration? 70 ml per kg of ORS. over 4 hours is the treatment of choice. What is called severe dehydration? Severe dehydration means the child is lethargic, not able to take feeds. Eyes very sunken. Eyes very sunken. Skin pinch goes more than 2 seconds. And finally, thirst, not able to take drink. Not able to take drink. And this is called severe dehydration. The treatment for severe dehydration is 100 ml per kg of RL with dextrose or NS with dextrose, not dextrose alone. RL with dextrose or NL with dextrose. So less than 1 year and 1 to 5 years. So you can give first 30 ml per kg and again 70 ml per kg. So totally 100 ml per kg is the deficit, that is the calculation you need to do. For 30 ml per kg less than 1 hour, you need to use 1 hour period, and 70 ml per kg over 4 or 5 hours. So the total is 6 hours. Whereas 1 to 5 hours, 1 to 5 years means you can do a rapid correction. So 30 ml per kg over half an hour and 70 ml per kg over 2.5 hours. 2.5 hours. 2.5 hours. So 3 hours. You can do fast correction with 3 hours. Now they will ask you another question. What is the indication for doxycycline? I repeat, what is the indication for doxycycline? Remember, the indication for doxycycline is in a child with cholera endemic area, and your cholera endemic area, and if the child is more than 2 years of age, you can use single dose of doxycycline 2.2 mg per kg stat. More than 2 years, cholera endemic area, 1 dose of doxycycline 2.2 mg per kg stat, only 1 dose, right? Okay, Rickets, it was discussed in detail, so I'm skipping out. Pneumonia I had. And one more point, but previously for each and every cases of fast breathing and chest in drawing, WHO guidelines or IMNCI guidelines says that you need to treat it as a case of pneumonia, but later on they found out that it can also be due to wheeze. So whenever you have a fast breathing and chest in drawing, you need to auscultate and see whether it is wheeze or not. If wheeze is present, either nebulized salbutamol or oral salbutamol as per IMNCI, and more than 2 weeks of cough, please rule out 2 things. One is asthma. The child may need controllers such as inhaled corticosteroids, or we need to rule out TB. That is what the IMNCI says. If the cough is more than 2 weeks, and important IMNCI adaptation as per 2022 are: one is saturation of less than 90 per minute. You need to shift the case to pink color, so you need to refer the case after giving ampigenta. And second point is, not all children with fast breathing and chest in drawing requires antibiotic. You need to see whether there is wheezes, the wheeze is there or not. If wheeze is there, you need to give salbutamol instead of antibiotics. Okay, now okay, this is okay, discussed. Okay, now what is this, my dear boys and girls? The only ECG that can be asked for you is the only ECG that can be asked for you in ECG in pediatrics is supraventricular tachycardia, SVT. So how do you know? Respiratory rate of more than how much? More than 220 per minute. And then whether one is tachypnea, respiratory tachycardia. Second one is narrow QRS. Second one is narrow QRS complex. Third one is no P waves. Third one is no P waves. This triad is called supraventricular tachycardia. So what is the treatment for supraventricular tachycardia? The answer is very, very simple. Whether with shock. With shock means you need to directly go for direct DC cardioversion. Direct DC cardioversion. Whereas without shock means you can give adenosine, which increases AV nodal refractoriness. This is for treatment for supraventricular tachycardia. What about prevention? What about prevention? Prevention means you need to see whether there a WPW syndrome is there or not. When WPW syndrome present, absent, and underlying cause for supraventricular tachycardia. When WPW syndrome is present means you can give only propranolol as a controller. Whereas when WPW syndrome is absent means either you can give propranolol or you can give digoxin One more MCQ, never ever try to give dash. What is that? Never ever try to give what? Try to give Verapamil. Verapamil is contraindicated in pediatric. The calcium channel blocker Verapamil is contraindicated in pediatric supraventricular tachycardia because it can induce congestive cardiac failure. So this has been discussed. Now, with respect to vaccines, I am going to concentrate only on general pediatrics, my dear. I am not going to concentrate on your systemic pediatrics. In fact, if it is possible, I will allot some more time. So misplaced. So again, so let me complete. Whenever the child, again vaccination, whenever the child is planning to do, whenever you plan to do splenectomy, you need to give 2 weeks before splenectomy, you need to give Haemophilus influenza, your pneumococcus, meningococcus, capsulated organism, as well as flu. Steroids, when the child is on this is with respect to vaccination. When the child is on steroids, that is 2 mg per kg for more than 2 weeks. I repeat, 2 mg per kg for more than 2 weeks means next 4 weeks no vaccine. Next 4 weeks no live vaccine at all. HIV, all vaccines are given if CD40. Yes, I am sorry, CD15. Okay. All vaccines can be given if your CD4 is more than 15% in asymptomatic child. In symptomatic child, the only avoided vaccine is BCG because it can produce BCG-induced TB. Preterm, remember, only vaccine that should be postponed. Only vaccine that will be postponed in preterm is hepatitis B. Do not give hepatitis B until the child weighs 2 kgs. Okay, right. Following chemotherapy, whenever you give chemotherapy, you are not supposed to give vaccines for the next 3 to 6 months. Chemotherapy. What about blood products? When you give blood products, it contains passively transferred antibodies. You are either FFP or blood or IVIG. Postpone your active vaccination for 12 weeks. Postpone your vaccination for 12 weeks. Okay, right, for 12 weeks. And then again, I am sorry, left out misplaced PPTs or PDF. Okay, again IMNCI, fever plus neck stiffness. Whenever you see any child with fever plus neck stiffness in, as per IMNCI, only 2 things. One is either it can be meningitis or it can be malaria. For meningitis, you will start the same AMP plus Genta. For malaria, you start quinine. Fever with abdominal pain. Anyone? Fever with abdominal pain. What does it mean? Fever with abdominal pain. Previously, IMNCI did not include dengue. Right now, IMNCI had included dengue in one of the differential diagnosis when any child presented with fever. And remember, positive tourniquet sign and cool peripheries. Whenever a child is presenting with it, you need to rule out dengue. Dengue was included. Fever with the clouding of cornea and mouth ulcers, you need to rule out measles, and all children will be requiring single dose of vitamin A. You must be saying that the role of vitamin K in measles is prevention of blindness. It is not so. The role of vitamin A in measles is it reduces overall mortality and mortality, morbidity and mortality. And ear discharge, as per IMNCI, acute means it is due to streptococcus pneumoniae, chronic means it is due to pseudomonas. Acute means you need to give amoxicillin for 5 days, Chronic more than 14 days means you need to give ciprofloxacin eardrops for 14 days. But when you have tenderness over the mastoid, I repeat, when you have tenderness over the mastoid, it should be called as mastoid tenderness or severe acute mastitis media. Then you need to refer the child. It comes in pink color, and give ampegenta and refer the child if there is tenderness over the mastoid area. Okay, right. What are all the two vaccines that is kept in amber colored bottle? So this is called amber colored bottle. Amber colored bottle, what vaccine? Heat sensitive or light sensitive? Light sensitive vaccines are kept in amber colored bottle. Light sensitive vaccines are kept in amber colored bottle. What are all the light sensitive vaccine? One is BCG, the second one is, what is this? MMR or measles containing vaccine. Those two vaccines are kept in freezer. The column next to freezer. Column next to freezer. The only vaccine that is kept in freezer is your OPV right now. The next column is BCG and MMR. Right. Okay, so as we discussed, in freezer you will store OPV. In the first rack just below the freezer, BCG and measles containing vaccine. The middle rack contain all T vaccine, DPT, TT, Tdap, typhoid, rotavirus, PCV, everything, hepatitis A, all stored in middle rack. And the lower rack is meant for hepatitis B, varicella and diluents. What is called shake test? Remember, OPVs should be kept in freezer, whereas your killed vaccines such as your typhoid, tetanus, TPT should not be kept in freezer. But accidentally, when you keep in freezer, how do you know that it has not lost its potency? Simple. You take the vial, shake it up, and see. Whenever you see uniform dispersal of vaccine particles, that vaccine is fit enough to give. Whereas whenever there is sedimentation of the vaccine particles in the diluent, it is unlikely to produce any antibody, so you need to throw out. So shake test is mainly for killed vaccines that should not be stored in freezer. For freezer, all live vaccines should be given subcutaneously. BCG, MMR, hepatitis A, varicella, influenza. These live vaccines should be given by subcutaneous route. Whereas killed vaccines such as your pentavalent vaccine should be, or a subunit vaccine or conjugate vaccine by pneumococcal should be given in intramuscular thigh. Normal, usually you use sterile water for all purposes, but for BCG and yellow fever you use normal saline as a diluent. Okay, right. So one spotter, what is that one spotter? So this is not a video, let me show you. So what is this cough called as? What is this cough called as? So whenever you cough continuously without any intervening inspiration, it is called pertussis. Whenever any cough is associated with the redness of eyes and tears from face, it is called pertussis. Whenever any cough is associated with post-tussive vomiting, it is called pertussis. And when any cough is associated inspiratory whoop, it is called pertussis. The drug of choice is azithromycin. Other drugs are clarithromycin, cotrimoxazole, and erythromycin, but the most common drugs that we use is azithromycin in pertussis. The common clues are absolute lymphocyte count will be very high, more than 15,000 cells per cubic millimeter. The only bacterial infection that is associated with lymphocytic predominant is pertussis. So any child with the cough plus absolute lymphocyte count is pertussis unless otherwise proved. The peculiar manifestation of pertussis in newborn age group is apnea. Instead of cough, apnea. Right. Okay, what else? And TB, what are all the things that you need to know with respect to TB? Very good. There are only, so cough more than 2 weeks plus fever more than 2 weeks. It is unless otherwise proved a case of TB along with the contact who had received ATT for the within the previous 2 years is called as TB. Cough more than 2 weeks, fever more than 2 weeks, and contact who received ATT within the past 2 years, along with the weight loss of more than 10% in the past not 10%, 5% in the past 3 months. That is called as TB. So for the next step is you need to do a X-ray test. If X-ray test shows 3 patterns, so look at this: fever more than 2 weeks, cough more than 2 weeks, and then weight loss. I am sorry, I misplaced weight loss. 10% in the past, previous guidelines are 5%, 10% in the past 3 months, and contact who took ATT for less than within 2 years is called as TB index. So you need to take a X-ray chest. In that X-ray chest, if it shows 3 particular pattern, a hilar adenopathy, a cavity, or miliary pattern. If it shows hilar adenopathy, cavity, or miliary pattern, then you need to directly go for CB-NAT, cartridge based nucleic acid amplification test, which is a point of care test, which will give you 2 things. One is whether it is sensitive TB or MTB, sensitive to rifampicin, and whether MTB is detected or not. But when X-ray shows no cavity, no hilar adenopathy, no miliary mottling, then you need to give a trial of antibiotics. This is very, 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 very important. But so what is the point of care test? It is not AFP, it is CB-NAT or gene expert. What is the gold standard test? Is culture. It is not solid culture, it is liquid culture, and the liquid culture is called as mycobacterial growth inhibitor tube system, MGIT, right? MGIT, right? Inborn errors of immunity. Yeah, rapid fire thing that we are going to see right now. Remember, whenever you see a case of a recurrent skin and soft tissue abscess, it is due to phagocytic disorder, and the most common phagocytic disorder that can produce skin and soft tissue infection is chronic granulomatous disease. Chronic granulomatous disease 1. Second point, whenever you have infection with the catalase positive organisms such as Salmonella, Aspergillosis, Candida, Staphylococcus aureus, Salmonella typhi, E. coli, Klebsiella, it is chronic granulomatous disease unless otherwise proved. Invasive aspergillosis is chronic granulomatous disease unless otherwise proved. Whenever you get recurrent consolidation or OPS, otitis media, pneumonia, sinusitis, after 6 months of age, it is Bruton's A gamma globulinemia, particularly if it is a boy. Whenever any child comes with albinism, along with hepatosplenomegaly, it is a case of, along with recurrent infection, it is a case of Țiriacă-Gashi syndrome, for which the investigation of choice is doing a peripheral smear and looking into giant granules in the neutrophils. Whenever any child between 2 to 6 months of age presenting with persistent pneumonia between 2 to 6 months of age with intracellular organisms like Pneumocystis carinii, cytomegalovirus, and BCG induced TB, then it is called T-cell disorder, particularly severe combined immunodeficiency. Whenever you have soft tissue abscess along with eczema, look for eosinophilia or look for thrombocytopenia. Soft tissue plus eczema with eosinophilia is hyper IgE syndrome. Soft tissue plus eosinophilia plus thrombocytopenia is Wiskott-Aldrich syndrome. Whenever you see any child with recurrent infection along with the ocular conjunctiva and ataxia, it is ataxia telangiectasia, in which IgA will be low and alpha-fetoprotein will be high. And then recurrent TB or recurrent typhoid occurs due to deficiency of interleukin 12 or interleukin 23 or interferon gamma pathway. It is called Mendelian susceptibility to mycobacterial diseases. Whenever you get hypocalcemia and a recurrent infection, it is due to Dye-Jar syndrome. Recurrent infection because in Dye-Jar syndrome, your fourth pharyngeal pouch will not be produced, which produces a parathyroid, whereas third pharyngeal pouch is responsible for production of thymus. So it is characterized by hypocalcemia and recurrent infection. Giant granules in neutrophils occurs in Chthiodiakigashi syndrome, whereas recurrent infection along with albinism also occurs in Chthiodiakigashi syndrome. Okay, right. What about storage disorders? Again, 𝐌𝐞𝐝𝐄𝐝 disease is due to glycogen storage disorder 1, glucose 6 phosphatase deficiency. Pompe's disease type 2, acid maltase deficiency. Cory's disease type 3 due to C followed by D, debranching enzyme deficiency. Anderson disease is characterized by A followed by B, branching enzyme deficiency. Your 𝐌𝐞𝐝𝐄𝐝, Cory, Anderson are associated with hepatomegaly and hypoglycemia, whereas Pompe's disease is characterized by accumulation of glycogen in the heart leading to dilated cardiomyopathy and floppy infant. McArdle's disease and Torres disease are associated with the exercise-induced muscle cramps because it is associated with the defect of glycogenolysis in the muscle. Whereas McArdle's disease is characterized by muscle phosphorylase, whereas Torres disease is characterized by phosphofructokinase deficiency. Okay, other things. Gaucher's disease is due to glucose cerebrosidase deficiency. Gaucher's disease type 1 is characterized by without neurological involvement, only hepatosplenomegaly. Whereas Gaucher's type 2 is characterized by fast neuroregression and death, whereas Gaucher's type 3 is characterized by slow neuroregression and death. In Niemann-Pick's disease, you have type A, B, C. A and B are characterized by sphingomyelinase deficiency and cherry red spot, whereas C is characterized by defect in cholesterol export transfer leading to generalized accumulation of cholesterol in the body in each and every tissue. Sandoff disease is due to 𝐒𝐿-𝐶 A and B deficiency, whereas Tay-Sachs disease is characterized by 𝐒𝐿-𝐶 A deficiency. Remember, among all these, the inborn error of metabolism that is not associated, that the lysosomal storage disorder that is not associated with hepatosplenomegaly is your Tay-Sachs disease. Also, characteristic feature are, what is this? Abnormal startle response and macrocephaly. Remember, macrocephaly, neuroregression, abnormal startle response, and cherry red spot is without hepatosplenomegaly is Tay-Sachs disease. Okay, metachromatic leukodystrophy is characterized by aryl sulfatase deficiency. Krabs disease is characterized by beta glucosidase, beta galactosidase. Fabry's is characterized by galactosyl ceramidase, and Farber's disease is characterized by ceramidase deficiency. Farber's disease is characterized by ceramide accumulation over the joints leading to rheumatoid-like nodules in the body. Very, very important. Rheumatoid-like nodules in the body. And finally, I am stopping my section with this very, very important. Remember the approach to organic aciduria. Approach to acute inborn error of metabolism I have been observing for the past more than 1.5 decades. So this tabular column is very, very important, and it will help you to find out, to crack at least one simple question. Whenever any newborn crashes immediately after birth, I repeat, whenever any newborn crashes immediately after birth, you all know it can be either due to congenital heart disease or PDA dependent lesion. So do an echocardiogram, it is normal. Then it can be due to sepsis. So your sepsis screen is negative. When it is not due to duct dependent lesion, when it is not due to sepsis, the next investigation of choice is serum ammonia. When serum ammonia is elevated along with your acidosis and ketosis, it is called organic aciduria. Acidosis, ketosis plus hyperammonemia. So when you have these three manifestations, then you need to look for skin manifestation. Skin manifestation present means it is biotin deficiency, multiple carboxylase deficiency. If skin manifestation is absent, mean look for urine order. If urine order is abnormal, then it is either isovaleric aciduria or glutaric aciduria. Neither skin manifestation nor your urine order means it is methylmalonic aciduria or propionic aciduria. The only inborn error of metabolism in which There is hypoglycemia, but there is no ketosis at all. Remember, all hypoglycemia should have ketosis. When there is hypoglycemia without ketosis, unless otherwise proved, it is due to fatty acid oxidation disorder. Again, after biotin deficiency, the most often asked question is with respect to fatty acid oxidation deficiency. And finally, there is no acidosis, there is no ketosis, but there is only hyperammonia, means it is called urea cycle disorder. Okay, right. So with this, okay, let me finish cardiac. So what is this? You have a figure of 8. You have a figure of 8 appearance. Figure of egg appearance. Figure of egg appearance usually occurs in case of transposition of great arteries. Whenever you have a term baby, large for date, no murmur, cyanosis on third day, it is transposition of great arteries. The first step is prostaglandin E1 analog. The second one is balloon atrial septostomy. The third step is correction, that is atrial arterial switch surgery. This is with respect to TGA. Okay, right. And finally, let me finish with this. So remember, congenital heart disease are basically classified into acyanotic and cyanotic congenital heart disease. Okay, see, acyanotic means it can be due to left to right shunt. Left to right shunt at the level of atrium is AST, at the level of ventricular septum is VST, at the level of large major arteries is PDA. Whereas another acyanotic congenital heart disease is obstructive lesion. Either it can be due to hypoplastic left heart syndrome or coarctation of aorta or critical aortic stenosis. Whereas your cyanotic congenital heart disease is characterized by one with increased pulmonary blood flow, another is decreased pulmonary blood flow. Decreased pulmonary blood flow means that your heart size will be normal. In decreased pulmonary blood flow, if there is right axis deviation, it is tetralogy of Fallot. If it is left axis deviation, it is tricuspid atresia. If the heart is very, very large, it is Epstein's anomaly. Right? Remember, the only cyanotic congenital heart disease with the left axis deviation is tricuspid atresia. Second one is increased pulmonary blood flow. It can be due to total anomalous venous connection, truncus arteriosus, or your transposition of great arteries, right? Transposition of great arteries. And finally, there are some great arteries. So what is this urine color? Alkaptonuria. So alkaptonuria is due to deficiency of what? Alkaptonuria is deficiency of what? Homogentisic acid. Sorry. So you have, what is that? Homogentisic, okay, oxidase deficiency. And finally, what are all the uses of cofactors in inborn errors of metabolism? Thiamine B1 is used in maple syrup urine disease. Riboflavin is used in mitochondrial diseases. Pyridoxine is used in homocystinuria. Biotin is used in multiple carboxylase deficiency, and B12 is used in methylmalonic aciduria. Very, very important thing. And as well as other things, yes, miglustat is substrate reduction therapy used in Gaucher's disease. Nitisinone, substrate reduction therapy used in alkaptonuria and thyrosinemia. And Lorenzo oil is used in X-linked adrenoleukodystrophy. Remember, 1, 2, 3, 4, 5, 6, 7, 8. You will get one MCQ from this definitely. So almost it is 11 to touch. Thanks for your patient listening. Keep reading, keep revising. All the best for your entrance examination. Bye-bye, friends.